Good evening, dear doctors. Welcome and thank you for joining us in this urology scientific webinar prepared by KUI in collaboration with Asino Company. Thanks to Asino Company for their active role in supporting all medical and scientific activities. And thanks to administration members of KUI, especially Dr. Akram, for his effort to involve all urologists. I want to inform you that if any participant had a question or comment, please write down in Q&A and it will be answered at the end of presentation. If special teachers can directly ask or comment by chatting. Thank you again. And Dr. Yadgar, if you're ready, please take the mic.
Dear Dr. Hassan, thank you very much. I don't know if my sound is clear or not.
نعم دكتور واضح نسمعك.
I will share my screen.
طالع السكرين تمام دكتور؟
Okay, my screen is clear?
نعم دكتور.
Okay. Thank you very much, Dr. Hassan, for your nice word. Good evening, everybody. Happy to be with you in the scientific event. Of course, you know our subject will talk about premature ejaculation. This is a common and debatable condition. That's why there are many institutes and associations talk about this subject. You can see this paragraph is from the European guideline. Urology talk about the premature ejaculation. Mention that although premature ejaculation is a common male sexual dysfunction, it is poorly understood. Patients are often unwilling to discuss their symptom and many physicians don't know about effective treatment. As a result, patient may be misdiagnosed or mistreated. As we mentioned, many associations and institutes talk about this problem, like American Psychiatric Association, WHO, European Association of Urology, American Urological Association, International Society for Sexual Medicine, and International Consultation on Urological Disease. But for any definition to be quite informative and strong in its content should include three important points. First one is the intravaginal ejaculatory latency time. Second one, the ability to control the ejaculation. And third one is the negative consequences on both couples. That's why the best definition till now is from the International Society for Sexual Medicine, which state that premature ejaculation is a male sexual dysfunction characterized by, first, ejaculation that always or near always occur before or within 1 minute of vaginal penetration in lifelong type, or a clinically significant and bothersome reduction in latency time, often to about 3 minutes or less in acquired type. In second point, the inability to delay on all ejaculation or near all vaginal penetration. And third one is the negative personal consequences like distress, bother, frustration, and or avoidance of sexual intimacy. This was end of my lecture. Thank you very much for your precious time. I will be happy if I hear your comment or question. I think one of this emoji will be the expression of your internal feeling when I terminate the presentation prematurely. So really, we are talking about a big problem. What do you expect if I invite you to view other presentation and every time I terminate my presentation prematurely without you getting the suitable information? So after that, there will be nobody who want to hear me. That's why really we are talking about a big problem, because this is a game between two persons. One of them, when he wants to start, every time the other, he finishes his job. We will return to our presentation. The classification of premature ejaculation, the latest classification classify the premature ejaculation into 4 groups. 2 of them are pathology, and 2 of them considered as a normal condition and just need reassurance and education. The first one is lifelong and acquired type. The lifelong, the patient has this problem from the beginning of his sexual activity, but the acquired type, there is a period of normal sexual activity. Third one is the natural variable. Usually this is occur in animal during his sexual activity may suffer from premature ejaculation, but usually this is an infrequent condition, and usually it is a situational and not need any treatment. You have also the premature light ejaculatory dysfunction. Usually this is a subjective type. The patient considers himself as a premature ejaculation, but when you discuss with the patient about the condition, you found he is quite normal. And usually this type of problem usually more common in a group of population who are fan of porn movies. Usually they try to compare himself to the porn stars and found he is quite abnormal. About the prevalence of this condition, according to the National Health and Social Life Survey, 31% of male population complain from premature ejaculation. But in the European study show that the percentage is slightly less, reach about 20% in all 4 types of premature ejaculation. What could be the etiology behind this problem? The theory talk about the hyposensitivity of 5-hydroxytryptophan to C, or hypersensitivity of the 5-hydroxytryptophan 1A, or physiological or psychological and environmental factor, or a combination of all these factors. This is about the long life type. About the acquired type of premature ejaculation, it's important to know the underlying cause may be sexual performance and anxiety, prostatitis, aging, hyperthyroidism, comorbid disease like hypertension and diabetes mellitus, erectile dysfunction, withdrawal or detoxification of recreational drugs, psychological and relationship problem. In the premature ejaculation prevalence and attitude survey, only 9% of men with self-reported premature ejaculation consult a doctor. The main reason is not for not discussing the premature ejaculation is with their physician are embarrassment and the belief that there is no treatment for this problem. Physicians are often uncomfortable to discuss sexual life with the patient, usually because of embarrassment or lack of training or the lack of expert in the treatment of premature ejaculation. Physicians need to encourage their patient to talk about premature ejaculation. About the relation between the premature ejaculation and sexual performance and anxiety, as you know, the anxiety will lead to increased sympathetic system activation, and this will lead to early emission phase of ejaculation. As you know, the ejaculation composed of 2 parts. First one is emission, collection of the seminal fluid in the prostatic urethra, and second one is the ejection or expulsion by the ischio-cavernous and bulbous spondylosus muscle contraction to expel the semen to outside the body. So the anxiety will lead to early emission phase. About the relation with the erectile dysfunction, many studies show that 50% of erectile dysfunction patient also has premature ejaculation. The reason is that first require high level of stimulation to achieve an erection. This is in patient with erectile dysfunction. Second one, the patient with erectile dysfunction intentionally rush intercourse to prevent early detumescence of partial erection. Third one is high level of performance and anxiety. About the relation to the prostate disease, several studies reported that the premature ejaculation as the main sexual disorder symptom in men with chronic prostatitis and chronic pelvic pain syndrome, reaching up to 77%. And some studies show that antibiotic treatment for documented bacterial prostatitis will lead to increasing the intravaginal latency time up to 2.6% and improve ejaculatory control in up to 80%. About the relation of premature ejaculation and hyperthyroidism, 50% men with hyperthyroidism will complain from premature ejaculation. But after treatment and normalization of the thyroid hormone, this number decreases into up to 15%. So if we have a patient with premature ejaculation, how we can evaluate? Of course, we will start from full medical and sexual history, a focused physical examination, inventory assessment of erectile function, and investigation suggested by these findings. And usually investigation only indicated in cases of acquired type of premature ejaculation. This questionnaire is from the European Guideline of Urology. It's very, very informative for diagnosis of premature ejaculation, differentiation between the type, and assessment of erectile function, assessment, relationship impact, previous treatment, or impact on the quality of life. So really, we found that this is very informative because usually the premature ejaculation is a clinical diagnosis. There are many measures for patient report outcome, and usually most of these measures used for statistical or researchable clinical studies. So what could be the treatment of premature ejaculation? It's very important to know that both parts of treatment, psychosexual therapy and pharmacological therapy, are important for patients with premature ejaculation. The psychosexual therapy, it's important to inform the patient about the prevalence of the premature ejaculation in the general population, so the patient feels that he is not alone. Second one, the average range of intravaginal ejaculatory latency time to dispel myths about the premature ejaculation, because most of the patient feel that the duration of ejaculation may be he feels that is more longer than that he expected. So that's why when you talk about the average range, he will understand that either he has a problem or not. About the behavioral intervention, it's important to learn technique about control and delay ejaculation, lessen performance and anxiety, modify rigid sexual repertories, surmount barriers to intimacy, resolve interpersonal issues that precipitate and maintain the dysfunction, and increase communication. There are two common techniques used as a physiotherapy to help the patient to delay his ejaculation. One of them is start-stop technique. In this technique, usually will ask the patient if he feels that he will ejaculate within a few seconds to stop his sexual activity and try to suppress his sexual stimulation. Sometimes he might use ice cold water on his genitalia to enhance detumescence. After that, within a few seconds, he will repeat his sexual activity, and he repeats this technique a few times with every sexual intercourse. Second technique is pause squeeze method. In this type, also, a few seconds before ejaculation, he should stop the sexual activity, and it's important to squeeze the glands of the penis, so this will enhance the detumescence, and after that he can start the sexual activity again, and he will repeat this technique a few times in every sexual activity. But there is a drawback to the psychological behavioral approach. Many patients consider it as a time-consuming, often require substantial resource of time and money, lack of immediacy, require the partner cooperation, especially for squeeze method, mixed or less well-documented efficacy. Furthermore, data to support long-term efficacy are lacked in this type of therapy. We mentioned that this subject is very debatable subject. That's why what I see on the net, there are many caricatures on premature ejaculation. This is one of them. the man say that the premature ejaculation is just another way of saying, really, I love you, to avoid the problem. Second line of therapy, of course, is a medical therapy using many drugs or interventions. Common drug nowadays used is dapoxetine. Dapoxetine is a rapid-acting and short half-life selective serotonin reuptake inhibitor. Could use in both type, lifelong and acquired type. Till now, according to the European Guideline of Urology, there is no drug interaction with phosphodiesterase 5 inhibitors. Although it's not approved by the FDA, but approved in the 50 or more countries worldwide. Usually use 30 or 60 milligram, 1 to 2 hours before intercourse. It found that can increase the ejaculatory latency time up to 3-fold, increase ejaculatory control, decrease distress, and increase satisfaction with minimal side effects like nausea, dizziness, diarrhea, and headache. But post-marketing experience reported that the discontinuation rate of dapoxetine was high, reaching up to 80 or 87% at 12 months. The reason for that is due to the cost and the lack of spontaneity associated with on-demand administration. Second line or second treatment, medical treatment, is daily-based selective serotonin reuptake inhibitor and tricyclic antidepressant. Either paroxetine or clomipramine, sertraline, fluoxetine, and citalopram is usually effective in delay ejaculation. But the potent one is the paroxetine, has a strongest ejaculation delay. It has an ability to increase the intravaginal ejaculatory length time up to 8.8-fold. Usually, the delay ejaculation will occur within one week or 10 days, but the full therapeutic effect will require 2 to 3 weeks. And the adverse effects are usually minor, start in the first week and may gradually disappear within 2 to 3 weeks. The common side effect is fatigue, yawing, nausea, diarrhea, or sweating. Although it is rare, but neurocognitive adverse effects like agitation and hypomania, it's possible side effect. On long-term use of this medication, weight gain and type 2 diabetes mellitus may be one of the side effects. Priapism is rare, but as an emergency condition and should be treated urgently. One of the side effects that you should consider when you give this medication to any patient with premature ejaculation is that this drug could cause abnormal sperm DNA fragmentation, so lead to decreased fertility ability of the patient. And usually this type of patient will have a normal semen parameter, but on DNA fragmentation study, there will be a high level of abnormal sperm DNA fragmentation. In daily use, selective serotonin reuptake inhibitor, it's important to remember two things. One of them is that any patient prescribed the daily SSRI should inform that he should not stop the medication abruptly. There should be a gradual titration for the drug because of the withdrawal problem. Second point is that the drug interaction, the selective serotonin reuptake inhibitor with codeine will lead to decrease the efficacy of the codeine. With non-steroidal anti-inflammatory drug, lead to increased risk of bleeding. With tramadol, lead to serotonin syndrome, and with MAO inhibitor also lead to withdrawal syndrome, and usually this is the presentation of serotonin syndrome like tachycardia, sweating, hyperthermia, and myoclonus, and agitation. On-demand administration of these medications that we mentioned that use in the on daily basis also could be used on-demand administration, but usually the less ejaculatory delay happen with on-demand use when you compare to the daily treatment. This is another caricature on premature ejaculation. The female rabbit tell the male turtle, "You are slow in everything except ejaculation, faster than Michael Schumacher." Of course, you know Michael Schumacher. Another type of treatment is topical local anesthetic. Use of lidocaine or prelocaine or a mixture between two produce a moderately effective in delayed ejaculation. But significant hypoanesthesia, penile hypoanesthesia, and possible transvaginal absorption result in vaginal numbness and resultant female anorgasmia unless a condom use make use of this type of therapy more stressful for some patients. Fortacine, this is a mixture of local anesthetic, spray. It's received marketing approval in Europe, and studies show that has the ability to increase the intravaginal latency time up to 6.3-fold. Phosphodiesterase 5 inhibitor, it's not indicated to use in patients with normal sexual function, just to treat the premature ejaculation. But in any patient with premature ejaculation plus erectile dysfunction, you can use the phosphodiesterase 5 inhibitor either alone if you expect that the patient has the main problems, the ejaculatory dysfunction, the erectile dysfunction, not the ejaculatory dysfunction, or you can combine with the selective serotonin reuptake inhibitor. Tramadol, on-demand tramadol is an off-label treatment. The efficacy was recently reported. Although the mechanism of action is not clear, but an anesthetic-like effect and central nervous system modulation through inhibition of serotonin and noradrenaline reuptake could be a possible mechanism for use of tramadol in delayed ejaculation. Use of alpha blockers, especially psilocybin, is a new treatment option for premature ejaculation. And many studies suggested that the placebo-controlled study assessment, its clinical usefulness would be worthwhile. That's why could be, especially those patients with BPH and treated by this type of alpha blocker. So many studies show that even the premature ejaculation resolved with use of this medication. Use of intracavernosal injection of vasoactive drugs is not indicated for treatment of premature ejaculation, although there are some few studies, but most of them are not reach the level to be accepted as a treatment. This is another caricature on premature ejaculation. This man has two wives. His old wife tell him, "I hope your new wife enjoy your premature ejaculation issue." Really, it's a big problem. What about emerging new drugs like DA8031 is a potent SSRI and used for treatment of premature ejaculation. Until now, it's under clinical trial. There are some studies done in South Korea. Also, highly selective oxytocin receptor antagonists used for treatment of premature ejaculation, like epilsiban, 50 milligram or 150 milligram, but still this is under clinical trial. Modafinil, although this is used for treatment of narcolepsy, but there are some studies nowadays use this medication for treatment of premature ejaculation via increased serotonin release in the brain and or spinal cord, or an action upon the dopamine system. Of course, you know, nowadays Botox, many field of medicine use Botox, injection of Botox to everywhere. Nowadays become a trend. In premature ejaculation, rhythmic contraction of bulbospongiosus and ischiocavernosus muscle during ejection phase of ejaculation may be inhibited by injection of botulinum toxin. Local injection of 25 to 50 units of botulinum toxin into the penis or frenulum, prepuce, or glans penis for treatment of premature ejaculation tested in many centers, but till now there is no any base or clinical research support to be published on this type of therapy. Selective dorsal nerve neurotomy or hyaluronic acid gel glans penis augmentation is not recommended for treatment of premature ejaculation. surgery may be associated with permanent loss of sexual function, and it is contraindicated in the management of premature ejaculation. This algorithm from the European Guideline of Urology shows the line of treatment of patient with premature ejaculation, and we discuss most of the line of this therapy. Thank you very much for your time. This is the real end of my presentation. I hope that you will enjoy during this.
We have some questions. I will start from Dr. Umar Dizay asks Dr. Yadgar, what is the role of BPH and prostatic operation in cases of premature ejaculation? Please, Dr. Yadgar.
Yes, my sounds clear?
Yes.
Yeah, thank you very much, Dr. Hassan, for your question, and thank you very much for Dr. Umar for his nice question. Really, there is no correlation between the BPH itself or the surgery for BPH and the premature ejaculation. But the treatment of BPH and surgery for BPH, we know that usually produce another type of ejaculation dysfunction, which is called anejaculation or retrograde ejaculation. But the relation with premature ejaculation, till now, there is no correlation with the premature ejaculation.
Yes, thank you. Thank you, Dr. Edgar. There is another question from Dr. Hushar Adel Karim. He says, what kind of laboratory investigation are helpful in premature ejaculation?
Yes, very nice question, Dr. Hushar. Thank you. About the investigation, in lifelong type, usually there is no need to send for any investigation unless there is expectation of any underlying etiology. For the acquired type, usually you should search for the underlying etiology or comorbidity for this condition. We mentioned that prostatitis, hyperthyroidism, some medical disease like hypertension, diabetes, all these conditions can produce some problem or end with premature ejaculation. At that time, you will need, for example, if you expect hyperthyroidism, you send for thyroid function test. If you expect prostatitis, you do some investigation for prostatitis. And if you expect the patient has some problem with medical disease like hypertension or diabetes, you might send for some investigation for this problem. Otherwise, usually the lifelong type, there will be no need to add any investigation.
Thank you again. Dr. Surin Azad asks, is there any direct correlation between age and premature ejaculation, and can happen at any age without exception or not?
Yes, thank you very much, Dr. Surin. The premature relation between age and premature ejaculation, many studies show that some patient with during his aging, he might develop premature ejaculation. Either there will be association with some underlying comorbidity, like one of the conditions that we mentioned, hyperthyroidism, prostatitis, erectile dysfunction, or hypertension, diabetes. Some of them has no this type of comorbidity. Only with aging, there is increasing risk of premature ejaculation. There is no direct correlation because some studies show that the aging will produce a delayed ejaculation by decreased sensation in the skin, by decreased sensitivity of the skin. But others show that some patients feel that he complained from premature ejaculation with increasing of his age. So generally, we can say either the aging will associated with comorbidities lead to the premature ejaculation, and some patients will have premature ejaculation just due to the aging process.
Thank you. Dr. Abdul Ghaffar Abdul Karim asks, is there any biochemical changes behind this problem? And the same question for retarded ejaculation.
Yes. Really, as I mentioned in the presentation, the hypothesis or the theory behind the premature ejaculation is more talk about the serotonin materials. That's why even the treatment is more concentrated on selective serotonin reuptake inhibitors. they talk about that the hypersensitivity or hyposensitivity of 5-hydroxytryptophan 1 and 2 respectively participate in the development of this condition. But really, till now, this is just theories on the level of the, let's say, the receptors and biochemical materials. But only also other studies talk about the relation between the dopamine and the premature ejaculation. But really, it's, until now, the talk is not so clear, and the studies is not so precious or confident in its decision about the biochemical level.
Thank you. There is another question about asking Dr. Luqman Botani, what about diabetes? What is the role of diabetes or relation between diabetes and premature ejaculation?
Yes, thank you very much, Dr. Luqman. Relation between the diabetes and premature ejaculation, you know that the diabetes mellitus by itself, it's a multi-system disease and produce a chronic inflammatory process in multi-levels. One of the levels is on the neuron or the biochemical level in the body. There may be some changes that happen in the serotonin receptors due to the effect of the chronic inflammatory process that affected by the diabetes mellitus that lead to production of this condition. And as I mentioned, this is just a theoretic answer. There is no, till now, a clear-cut study or answer that what's the direct relation between the diabetes mellitus and the premature ejaculation. But they found that the presence of diabetes mellitus in the history of the patient will increase the risk for development of premature ejaculation.
Thank you. Dr. Riva asks about, is there any clarification about mechanism of action of SSR inhibitor in prevention of premature ejaculation?
Yes, we mentioned in the causes of especially long life type of premature ejaculation and even the acquired type, they talk about the hypersensitivity or hyposensitivity of 5-hydroxytryptophan serotonin receptors, type 1 and type 2 respectively. That's why use of this type of medication, selective serotonin reuptake inhibitors, act on the level of serotonin receptors that lead to increased level of the serotonin in the synapse, and this will enhance to delay the ejaculation by effect on the receptors that we mentioned.
Thank you. Dr. Him Said asks, what is the relation between cardiovascular disease and the premature ejaculation?
Really, there is no clear-cut correlation. Just studies show that patients with acquired type of premature ejaculation, the presence of the hypertension or vascular disease may be a risk factor for development of this condition. Otherwise, there is no clear, let's say, prescription for the condition that what happens if the patient has heart disease, cardiovascular disease, hypertension, why lead to premature ejaculation. As you mentioned, till now, the premature ejaculation is very debatable and it's not so clear in many levels. And still, many institutes and associations discuss this subject to more clarify the underlying pathology of the premature ejaculation.
Thank you, Corrector. There is another question from Dr. Hunar Mahmoud asks about, is diabetes causing premature ejaculation or mostly dry ejaculation? Which one is more?
Very nice question. Diabetes mellitus by itself can produce all type of ejaculatory dysfunction, either retrograde ejaculation or anejaculation or even premature ejaculation. As I mentioned, there are some studies show that could consider as a risk factor for premature ejaculation. The underlying cause, as I mentioned previously, that it is due to a chronic inflammatory process in the neurons at the level of the synapse that produce some change, lead to ejaculatory dysfunction in any type that we mentioned. For example, in the it could affect the nerve supply of the bladder neck, lead to wide bladder neck and lead to retrograde ejaculation, could affect the nerve supply of the vases and seminal vesicle, lead to anejaculation, and could affect the nerve supply of the penis and end with premature ejaculation. And there are other studies show that even diabetes mellitus could lead to delay ejaculation also by decreased sensation in the skin of the penis. This is also so that really the diabetes mellitus is a multi-directional bad effect on many systems.
Thank you. There is a comment, I don't know his name, FutureNet is asking, there is a commenting that all drugs used for premature ejaculation suppress sexual stimulation centrally. What's your comment about this sentence?
Yes. If you see the all type of medical therapy, most of them will act on decreasing the stress of the patient to decrease its anxiety. And one of the line of the treatment is to either by drug or just by the psychotherapy is to decrease the sexual performance and anxiety. And decreasing the anxiety by itself can lead to delay ejaculation or prolong the duration of sexual activity. Although one of the side effects of this medication could end with decreasing in erectile function. Yes, it's quite right. But usually the doses that uses in this type of therapy uses in a dose that could not cause some this like problem, as we mentioned, ejaculatory erectile dysfunction, or produce some type of depressed activity. So the main line of treatment is two lines. Is first decrease the anxiety performance of anxiety, and second one is acting on the nerve level, on the serotonin, to increase the duration of the sexual activity.
Thank you. There is another question from Dr. Shahwan says, could you specify which kind of therapy has most positive feedback in your practice?
If I talk in a right way, in my practice, what I see, and even before one day I collect all my patients that I see with premature ejaculation, I see really within the last 5 years, I see 83 patients with premature ejaculation. Of course, some of them, or most of them, not present to me with premature ejaculation. They are present with another problem. But during history taking, I catch that the patient also has a premature ejaculation, but due to the factors that I mentioned, like embarrassment, or he feels that this condition is normal and no need for any treatment, or there is no treatment for this condition. What I see, generally, we divide the patient into two parts. If the patient has a frequent sexual activity, and he is sexually active, and he frequently needs to do sexual activity, we prescribe for him paroxetine on daily based treatment, because the patient will has a frequent sexual activity. It's not suitable to give him on demand. But those patients who has infrequent sexual activity, 2 to 3 per month, most of them we prescribe for him the on-demand dapoxetine. But if you want the real talk, the daily-based treatment is really more effective than the on-demand one. And usually, most of the patient, what I see that is the dapoxetine on-demand use, they convert it to the daily-based use after a while.
Thank you. There is another question from Dr. Umar Dazai, asks about the role of antidepressant in management of premature ejaculation.
Yes, one of the treatment that use is antidepressant, and as I mentioned, this is just to decrease the anxiety. The antidepressant will use as a anxiolytic drug to suppress the performance and anxiety of the patient. So even antidepressant could be used in some patient with premature ejaculation, and some patients take benefit from this type of therapy. And some patient, maybe 2 to 3 patients, I have patient with depression, they visit a psychiatrist for treatment of his problem of depression, but he follow that after treatment of taking of antidepressant, he feel that his ejaculation become better. After discussion, we see that he has a history of premature ejaculation previously, but he didn't visit any doctor to treat this condition. But for treatment of the depression, he feel that his ejaculation become better.
Thank you, Dr. But there is, I have a comment or an interference. Is everybody or every couple or man, if his ejaculation time is less than 1 minute, he need this treatment, or only those who is when this ejaculation causes problem to the partner? This is first.
Yes.
The second,
yes.
The second question is that it is as I heard from you, it's the intravaginal ejaculation latency time is 3 minutes. Isn't too long? This is too long for couples. Yani sometimes it may be okay for new couples, but what about others? Example, for middle age or elderly, isn't too long, especially when you increasing age. Patient will have more cardiovascular disease, they will have hypertension. Is this time of 3 minutes or 3 to 5 minutes, is it okay for every age, or should be specified for young people and elderly like that, or those who have heart disease like that? If you have, give me an answer, please.
Yes, thank you very much, Dr. Hassan, for your question. About the first question, either every patient should take the treatment or not. You are right. Not every patient need the treatment. That's why we mentioned in the presentation that although the percentage of population that has premature ejaculation ranges between 20 to 30% in Europe and United States of America, but only 9% they visit the doctor for treatment, for seeking for treatment. That's why when the couple, the male and the female, if they have no problem with this condition, usually will not produce a so big problem. But many patients, when you discuss the condition with the patient, after that he think about the condition. He say, yes, really I have a problem, but I didn't feel that this is a treatable condition. And any embarrassment may be a causes for this condition, because ejaculation in less than 1 minute really produce a very stressful condition for the male and for the female, because the time of getting orgasm between this couple, it will be very difficult to be conjoined in the same time. That's why produce a problem for them. About the 3 minutes or more, usually for lifelong type, is according to the definition of that we mentioned, the 1 minute is for the lifelong type. The 3 minutes is for the acquired type, especially those who have longer duration of ejaculation previously. So when his ejaculation reach to 3 minutes or less, he feels that he has a premature ejaculation. But you are right, when the patient, especially elderly patient with many comorbidity disease, this type of patient, as I mentioned, the psychosexual therapy is one of the important points for the patient. You should discuss with the patient about the prevalence of this condition, about the time, and about the comorbidity and the side effect of the medication. At that time, you will decide to add a medication to the patient or not. So what I want to say is that not every patient need to be treated by medication. Only the psychosexual may be a suitable choice for the patient. But patient with severe, let's say, problem with this premature ejaculation, he has a distress, he has a relationship problem with his wife due to this problem, really are in deep need for medical therapy.
Thank you, Dr. There is another question. We are talking about ejaculation and premature ejaculation. What about the orgasm in female? What is the time or actual time or usual time for the female that usually needed to get orgasm? And
Yes.
I asked many gynecologists about this. No one give me an true answer. And there is a real thing that most females, they have little or no idea about orgasm, or most of them, they are not getting orgasm with every sexual action, as I heard or read from books. Can you give me an idea about time needed for that in a textbook, or you read it somewhere, in female, time needed for female to get orgasm?
Dear Dr. Hassan, really, I have no such a good idea about the orgasm in female, because this is out of our field. But what I want to say is that the premature ejaculation, why it's problem for the female also, because most of the patient have the problem in the orgasm of the female. The male say, okay, I have no problem. I get what I want, but my wife has a problem. Every time she blame me that you have a problem, and when I want to start, you finish your job, and will produce a relationship problem. But about the time, really, I don't know the real time about the orgasm in female, and this is maybe a good question. We want to, if possible, we will search or ask some of our colleagues of gynecologists to find a good answer for us about this problem.
Thank you. This will be a good option, good answer for most of us, because to know the gynecologic view about this point, this will help us in deciding whether this patient needs treatment or not. And there is another comment. When we treat patients, most patients that I saw and treat them, I usually choose citalopram. They are it's very effective, and they get good response. But most of them, they ask me later, for how long I should take this medication? Shall I continue forever? And I'm facing this question to you. For how long they should use this medication?
Yes, Dr. Hassan, according to the European guidelines, mentioned that you can continue the medication for about 8 weeks. After that, when the patient feels that he is well, you can start to graduate. That I talk about the daily doses. The on-demand dose, usually the on-demand dose divided into two groups. Some of them, when the main problem is the anxiety performance, most of them, they will be well, and after few months, they will be happy without taking the medication. But for those patients who have underlying real pathology or underlying abnormality in the neuronal levels, those usually their condition with stopping the medication, it will reoccur. That's why, as I mentioned, that risk of stopping taking of on-demand dapagliflozin reaching up to 80% after 12 months of administration. This was really my answer about.
You are talking about on-demand. On-demand, this is used for those who have occasionally sex 2-3 times per month. But for young and sexually active men, they are doing that daily or more than once a day. At that time, you need continued dose, not on demand.
Yes. I mentioned, as I mentioned, what mentioned in the European guideline is that after 2 months, that the patient feels that he is well, 2 months of normal sexual activity, you can start to graduate, titrate the dose until stopping the medication and follow the patient.
If recur,
you should start the medication. Some of patients may need a longer duration, and some patient may not be in need to repeat the medication.
Thank you. Dear participant, anyone to have a chat or comment, please? Just raise your hand to see if anybody want to interfere or any comment. Please raise your hand. No one?
I think there
No
is one want to.
One? Which one? I don't see.
Really, I want to. No, I think he cannot raise his hand.
Ah, there is no one.
Yes.
Okay, I want just Dr. I want to ask Dr. Lian a question, or just if she give me an explanation. We are prescribing ciprofloxacin daily for too much patients. Do you advise the patient to have the drug after meal or before meal, especially those who have gastric problem? This is one. The second, when you give the drug prescription for patient with chronic prostatitis, they take the drug for a month or 2-3 months. Where they should store this drug, in the room temperature or the refrigerator? Can you please answer me?
Yes, dear doctor. The first question was about the best time for administration of ciprofloxacin. Doctor, as we know that ciprofloxacin is known to be gastroirritant, so it's always best to be taken after food, okay, with a full glass of water in order to minimize the gastric irritation. And about the storage, we can see for most drugs, it's written on the pack that it should be not stored above 25 or 30 centigrade, let's say about room temperature. However, we should advise the patient, especially in the hot summer, in order to not leave it in a room that doesn't have any AC or conditioning, or in the winter, we have to make the patient to pay attention that for not keeping the medication near, let's say, a hot source or a heating source. This is very important because most of our patients think at room temperature it's okay to leave it anywhere.
Thank you, Tulian. What about the most common drug interaction between ciprofloxacin, and we usually prescribe it with tamsulosin? Is there any drug interaction, or sometimes you give it with analgesic or non-steroidal anti-inflammatory drug? Can you tell us, please?
Doctor, for drug-drug interaction for ciprofloxacin, it's known to be not that much. The most common one is actually with the antacids, especially the magnesium-containing antacid. However, for those drugs, it doesn't have that much of drug-drug interaction. However, it's always better to advise the patient to separate any two medications if they are taken simultaneously, to be separated within 1 or 2 hours between the two medications.
You mean that there is no major drug interaction with tamsulosin and non-steroidal anti-inflammatory drugs,
yes,
which is usually prescribed? Yes. What about urine alkalizing agent we usually use for those with prostatitis? Do you agree with me, Dr. Yadgar?
Sorry, really, I have a problem in my mic. I didn't hear you well. Say, what was
I'm asking, is there any drug interaction between ciprofloxacin and urine alkalinizing agent that we usually prescribe for patients with acute prostatitis?
Yes.
I'm asking Dr. Lian, is there any drug interaction, or if she couldn't answer, if you can give me an answer, please.
Really, I didn't read or hear any interaction between the alkalinizing agent or with ciprofloxacin or quinolone group as a general.
Dr. Lian?
There are no major drug interaction. Maybe you want to pay precautions, let's say. However, for let's say if it is contraindicated to be given together, there is no such a drug-drug interaction.
Okay, thank you. Thank you for this nice discussion. Is there any question from anybody, please?
Doctor, I think there are new questions in the Q&A section.
Okay, I will see. And just Dr. Hunar Mahmoud said, just comment, most medication is not curing, only temporary. Most medication used on it. This is Dr. Hunar Mahmoud, and Dr. Umar Dizay asks, is there any relation between spinal pathology and disc prolapses with premature ejaculation?
About the relation of course, comment of Dr. Hunar is quite right. Many patients produce, especially the on-demand one, produce just a temporary effect. And usually, as I mentioned, it's more useful for those patients who have performance and anxiety. About what was the second question? Sorry, Dr. Hassan.
Is there, just a minute to see.
I think you mentioned about spinal surgery.
Yes, spinal surgery, spinal pathology.
Yeah, spinal pathology, of course, the neurological disease generally and spinal pathology more related to the anejaculation and delayed ejaculation than relation to the premature ejaculation. What I see is that really I didn't find any relation between the spine surgery and premature ejaculation.
There is another comment says that is frequent masturbation in pre-marriage stage period is a cause of premature ejaculation, or there is no relation?
There is no direct relation between the frequent masturbation with premature ejaculation, but usually those patients who have the pre-marriage frequent masturbation have more sexual performance and anxiety than other people. They feel that they feel that they are more satisfied when do masturbation than when they do normal ejaculation. That's why they may suffer from some form of premature ejaculation. But usually this type is let's say a temporary one, and usually by psychotherapy and with some medication, they will get benefit and their problem will resolve.
Thank you. There is a question for Dr. Lian from Surina Azad, says, is there any difference between ciprofloxacin and levofloxacin in the term of bactericidal activity against E. coli?
Yes, doctor, I can see the question here.
Yes.
The difference between them, let's say, doctor, even the doctor has, Dr. Sorin has mentioned a study that says that levofloxacin has achieved bactericidal with the minimum inhibitory concentration, which is less than 32 microgram. Doctor, we all know that different study has, let's say, many studies has been run according to this subject. We also have a study in the American microbiology that says that ciprofloxacin achieved a bactericidal effect on E. coli with only 5 microgram in liter and only within 15 minutes. We can say that, however, these are, let's say, minor differences between ciprofloxacin and levofloxacin. The main factor here that could affect the choice of the medication, it is the penetration capability, and we can see from the guidelines that it didn't prefer levofloxacin over ciprofloxacin in this situation. However, most of the guidelines in the opposite preferred ciprofloxacin in case of bacterial prostatitis. However, inshallah, I will provide Dr. Sorin with a study about ciprofloxacin bactericidal efficacy against the E. coli and also the Pseudomonas, because usually they run these studies together.
Thank you. There is a question for Dr. Linia from Dr. Umar Dizay, says, do you think that there is possibility of pseudomembranous colitis in long use of bactiflox in chronic prostatitis? Is there possibility?
Yes. Of course, doctor, the pseudomembranous colitis is a side effect of any antibiotic long exposure, not only, let's say, ciprofloxacin. However, for the chronic prostatitis, as you know, doctor, even if this possibility is there, still, let's say, the benefit outweigh the risk, especially in such case of chronic prostatitis. Of course, it's a side effect of any long antibiotic use. However, in case of chronic prostatitis, it is not that much, let's say, reported. And even if it happens, it's still, the benefit outweigh the risk in this case.
Thank you. It means that if the patient, we should tell the patient, if you develop diarrhea, you should stop the medication, and see your doctor to get treatment.
Yes, yes. However, doctor, usually we see this with, let's say, more broader spectrum antibiotic. We can see here that ciprofloxacin mainly, let's say, focuses on the gram-negative bacteria and the Pseudomonas. With those antibiotics that have a broader spectrum, both, let's say, gram-positive and negative bacteria are usually associated with this side effect.
Thank you. There is a comment from FutureNet says, on repeated trial, the patient should have same complaint. Otherwise, it is not premature ejaculation. It means that if you give me, I want to explain. It means that if the patient, I will change the comment from my idea, my side. Some patients said, I have premature ejaculation, Dr. Yadgar. And I ask him how frequent you are doing sexual intercourse. If he tell me that he will do it weekly or 2 weekly interval, I will tell him this is not premature ejaculation. Because from the definition, it should be, even if you do it frequently, then it should be the same result should happen. Do you agree with me or not?
Dr. Hassan, you are quite right about the definition of premature ejaculation. Really, you should concentrate how the patient want to define his problem. Many patients, he give you a false idea about the premature ejaculation, either because of giving of wrong subjective feeling of the patient, or misdefinition for the premature ejaculation. You are right. As I mentioned in the definition, he should have this problem in all or near all sexual performance, not infrequent. So if you have a patient, he may have some premature ejaculation, let's say in less than 10-20% of all his sexual activity. This is not considered as a premature ejaculation. There may be some situational and conditional factors that lead to this premature ejaculation. The problem of premature ejaculation should be present in all or near all sexual activity of this patient. At that time, you can define that the patient has premature ejaculation, and you will proceed for managing of his problem.
Thank you. I want just to tell you something as a joke. Yesterday, I saw a patient, two partner. The man was asking me about, he said, he was looking to me and his wife is sitting beside him and tell me, doctor, I have no desire. I have lost my desire to sex. I am seeing my wife as a man. When I turned my head around to see his wife, she was really more ugly than a man. She was just like cattle, the cows. That's why, and this is if we change this job to a real life, the relationship between the partner, the degree of relationship, strong relationship, it will affect the premature or retarded ejaculation. Am I right or not?
Yes, you are quite right. One of the main causes of premature ejaculation is, as I mentioned, the sexual performance and anxiety due to of unhappiness, a problem in relationship with the partner, also produce could be a risk factor for this problem, and of course the decreasing the desire make the man to feel that to want or to decide that to terminate his intercourse in a very short period, to just leave the condition.
Thank you. If there is no more question or any comment? Yes, there is someone raising hand, Dr. Hunar Mahmoud. Yes.
Okay, doctor, we will unmute.
Yes.
Hello?
Yes, Dr.
Do you hear me?
Yes, yes.
Yes. I just want to make. Do you hear me now?
Yes, yes, I'm hearing you. Yes.
Do you hear me? Okay. I just
Yes.
want to make a comment on Dr. Lian, just for her ciprofloxacin medication. We are living now in, do you know, COVID-19, too many people using multivitamins, zinc, you know, vitamin C, most of them using at home. And these ciprofloxacin usually have drug interaction, mostly with the medication which containing calcium. Even we are living now in summer. Now we are summer. In summer we are using too much yogurt. You know, in Erbil we are using too much yogurt, and even milk. Yogurt and milk containing too much calcium. Better when you prescribe this medication, ciprofloxacin, better to tell the patient if you are taking multivitamins, try to avoid multivitamins when we are using ciprofloxacin, or even the food which containing rich in calcium, like yogurt and milk, better to be avoided. That's just want to make a comment for her interaction.
Yes, thank you.
Thank you.
You, Dr. Hunar.
Thanks a lot, Dr. Hunar. As we have mentioned, Doctor, it's always right for the, even not only for the multivitamin that containing magnesium and calcium, also we have mentioned for the antacid. However, they can take it, but the most important thing is to separate between them. For example, let's advise the patient not to take the multivitamin unless 4 or 6 hours after taking ciprofloxacin, which we will allow the patient to take them both, but we have to separate them by time.
Thank you, Dr. Liam. Thank you, Dr. Hunar Mahmoud, for your comment and interference. Is there any comment, please? No? Do you have anything, Dr. Riyad?
Finally, really, I want to extend my great thanks for Dr. Hassan, who moderates this webinar, and we are in great thanks for Asino team for their help in logistic preparation for this webinar. We hope that all our attendees take some good message from this presentation, and I hope that all of you will be in safe. Thank you very much for all.
Thank you. Thank you, Dr. Lian, for your nice presentation and your very good language. And thanks for all the participants. At the end, I want to say, God bless you all, and Mubarak and happy Friday tomorrow. Thank you, and I hope to see you again in our next seminar. I hope so. Thank you.
Thank you so much, Dr.
Hassan
and Dr. Edgar. On behalf of Asino Company, I would like to thank all the attendees and would like to thank Dr. Edgar for his informative lecture, and Dr. Hassan, thanks a lot for being with us today. We are honored by that. As you have mentioned, hope that we can make this happen another time. Looking forward for another webinars with you all. Thank you so much.
Thank you, and goodbye for all.
Goodbye.
Goodbye for all. Thank you very much.